So, as you know, Korea has already entered an aging society with a proportion of senior citizens aged 65 or older exceeding 16.7% to 2021. So nowadays, many doctors, orthodontists use that from bracket to aligner. But as you know, the bracket is very excellent appliance for tooth movement. But unfortunately, the bracket is very, uh, the patient doesn't like that because it's unaesthetic and sometimes there's a heavy force releasing that the patient complain about the pain. So because of that, I developed a 0.08-inch coated nitrile wire. That is a hair thickness. So before developing the E-wire, I used that only this case is only wire. So let me show you the upper minor crowding and lower incisor is minor crowding. So this article, this case report was published in KJO and two, 2013. So the first times I engaged bonding the 012 NiTi wire like that, and 2 months later, this test was moved. After that, we engaged the NiTi spring and introduced the upper lateral incisors. And after that, I bonded the 014 slot tube and the 16, 12 NiTi wire, engaged that. And 9 months later, this cases was completely finished. So because of that, uh, I use that. Uh, this is indirect jig. It was devised. It's the blue color was that the transfer jig remnant. So jig remnant was that. After that, 2 months later, the minor crowding was relieved and the retention. So before and after, the taste was very uh, good, excellent. But you know that the only we use that wire without a clearance, the taste is moving like that. That makes a spacing. So because of that, I used the E-wire, uh, coating wire. So, and the retention. So this case means orthodontists can create the only wire, not tube or bracket. It's very easy and simple. So, but if we permit the clearance for tooth munch, this case, it's for a long time, a bonded retainer, canine to canine stainless steel retainer, but unfortunately, this case was relapsed. So we used that U-wire, and 2 months later, this is perfectly recovered. And 3 years later, it's perfectly maintained. So that means very small size wire can move the anterior teeth. Don't use bracket or heavy furs. So 2020 is also well maintained. Uh, so, so because of that, I have to I have to make the clearance. There's a coating material. So place the E-wire coated on the tooth surface like this. And over the coated wire, we apply the resin and cure it and remove the coated material with water rinse. That is a clearance formation like this. In this case, the wire is simply moved. So the clearance is only 0.002 inch, that is 0.05 millimeter, made by washed out of the coated material. So the wire is easily moved in the room. The PGA, the material is a PGA, polygamma glutamic acid, water soluble, non-toxic, and easy to manage, produce the clearance. That so if you coat it with E-wire and water spray, the coating wire is release the uh, melt the like this. Yeah. Okay. Let me show you again. If you bond the E-wire in the mouth on the teeth, after that you spray water spray. Uh, the wire is the coated material rapidly removed like this. That means the clearance was made. So coating wire, 1 minute, 2 minutes, 3 minutes, 4 minutes, 5 minutes. If you're bonding the E-wire in the teeth, after that, you wash out the water spray. That's why is within 5 minutes, totally removed. So it's very interesting. The wire is a white color, but over there it's resin. If we move in this case, the wire doesn't move. But if they remove that coating material and you pulled the wire like this. In this case, if you pull the wire doesn't move anymore. But in this case, you pull the wire like this. That is a minimal clearance can move the teeth. So now I recommend two wire. The labial is E-wire, that is the first wire. Lingual is velodrome wire, the second wire. Labial wire is a round wire. Velodrome wire is the flat NiTi wire. So there is hair thickness 0.08 inch or 0.010, and the coated wire PGA like this. And if you place the E-wire labially, the totally correct the 70 to 80%. The first wire. After that, uh, the second wire is a lingual wire, it's a velodrome wire. So it's also coated wire, and the thickness is a hair thickness, but the shape is not round, only flat. So if we place the velodrome wires lingually, the 20 to 30% improved of the total treatment goals. That is a finish wire. So let me show you the uh, video. Let me introduce this step-by-step procedure. If you place the posterior part, you can use that tube or bracket, but the other side is a removable P-clip. That is a clip. So the coating wire is very sensitive to moisture. You have to stabilize the posterior part like this, tube or clip, and insert the coated wire like this. After that, the A-clip was placed in the anterior part, and flow E-pusher, and push the tooth surface tightly as a not gap, only the tightly push that tooth surface and cured it. And the other side is the same powder spray and remove the coating material, and roughly 70% to 80% was crowding was relieved. After that, we placed a lingual side velvet wire, and step by step. This is a dental floss. If you use that, this appliance is tightly contact to the lingual side, not but anyway, bonded retainer. This is finally uh, substitute to the bonded retainer, and finally, and this, and finally, yeah, like this, yeah. So there's sometimes a beginner the how to position this UI precisely. So for we made this procedure for them, microbrush and the microbrush tip as cut off and bend like this, and place that the wire place the position and mark and the pencil like this. After that, resonating. Okay, 안 보이시나? And press that microbrush tape just like that, makes a slot and the curing, and that is roughly made the slot, and we place the E-wire at the made slot and overclock resin adding and curing, and the curing and the washout. Yeah, washout. This is a coating material, and after washout, the NiTi wise color is appeared. So in this case, we put okay, okay. The wire is pulled out. Yeah. So anyway, the clearance making procedure is very important to E-wire. That is a direct method. This is an indirect method. This is a jig for precise position. Apply the lubricant and like this, adding the resin. They place the jig on the crown and curing, and like this. So if you wanted to precise position the E-wire, I recommend the E-wire jig for beginner. Yeah. So new version coated E-wire is placed labially first. It's 1 month, 3 months, and 4 months, and lingually. In that stage, we didn't develop the velvet wire. The lingual side is a round wire, and so this is a round wire. Labial and lingual is only round wire only. But after that, we plate wire. That is a flat NiTi wire. That is developed from the round cross-sectional form and pressed at the both sides and like this. So not round, this transform. So multi-directional force delivery system for considering dental allergy. Yeah, plate wire. So the first level is very light. So this wire is, this is kind of a carbonite wire. The room temperature is the wire is very thin, but in the room temperature, uh, oral cavity, the wire is reformed. Yeah. So this is very simple case. This patient was used at the aligner for a long time, but the patient doesn't comply. So the appliance. So we have this patient referred from the another clinic. So we use that the labial side is the E-wire, and the after E-wire, and so we placed the lingually velodron wire as 2021 September, and 2012 after 2 months later, this wire is slightly for a long time so stable. Yeah. So after that, we have to monitor this for a long time. It's so stable. So the other case is the patient wanted to upper aligner and lower is the EY. Aligner is applied at that. After that, we place the lower EY labially first, and 3 months later, and 2 months later, lower incisor crowding was roughly released. After that, we placed the lingually velodron wire. But 3 months later, the velodron wire is perfectly. 4 months later, is substituted retainer. So this case means if you use the lingual velodron wire, you don't need anymore another bonded retainer. The velodron wire is substituted that retainer. So before and after. So plate wire's cases, let me show you. This is first and second molar level is different, lingually tipped. So we place the plate wire like that. After that, this wire is sold. So it's very easy. Yeah, the plate wire is very right releasing appliance. So the other case is gingival recession and the lower right canine was lingual tipped severely. So we place the labial E wire and plate wires bonding the like this. After that, we place the lingual velodron wire. So finally, we got it. Yeah. So very light first releasing device is a light E wire and the velodron wire. So you can easily use this appliance for the minor case. This case is a young guy has upper high canine and lower severe crowding. So like this, yeah. So summary case, yeah. The first step, the ABP for deep overbite correction is 3 months later. And 9 months later, lower incisor crowding was uh, corrected naturally. Yeah. So, so ABP wearing is a driftodontics, induced that driftodontics as a crowding relief. We didn't use any appliance in the lower arch. And finally, we upper velodron wire like that and wait. And the minor spacing was relieved, but we cut up the wire and the canine portion and like this. Space closed and cut up the middle portion. So like this. even level lateral incisor like this. So before and after. This case is only I use that upper is labial E-wire, lingual bilateral wire, and upper is perfectly correct, and the lower is in this case labial E-wire first, and lingual bilateral wire, and yeah, it's very easy and simple. Yeah. So in this case, I used only ABP and the UI and bilateral wire, upper and lower. Yeah. So bilateral wire is like this form. It's a bike track. So inclination was 3 to 40 degrees. As I mentioned before, the round wire is pressed like this, and the lingual placed. Yeah. So this bilateral wire is very soft. So in this case, crowding is severe. So you can bond it easily like this. Yeah. And 1 month later, and next 2 months. Yeah. It's very easy. So, uh, so, so E-wire means the coated wire, no bracket. That is a kind of a tube system, but no ligature, with a very light force releasing device. So you send me the 10 questions. So one by one, I'm going to answer these questions.
Yes.
Okay.
So we have collected through pre-survey your questions.
No, you can carry on, Miss Han.
Yeah, okay. So let me just call the question. There were many common questions, so I've narrowed it down to 10 questions. The first question was mode of action and how it works.
Mode of action is almost the same, the bracket system. Bracket system, yeah.
And I think we've been through enough of our product information, so I'm going to skip the second question. And also the third question was protocol and how to use E-wire. I think we've covered that enough in the presentation. And question 4 was range of action. I think it's range of like indication, I guess, which cases we can apply.
So the minor crowding and spacing and the relapsed case is very useful. But so sometimes a complex case is possible. Let me show you a complex case. 아까 공유한 게 어딨죠?
공유했던가요?
네. 지웠나요?
아니요.
그거 올렸구나. 다시 한번 볼까요?
이러고 하면은
네, 저처럼. Complex cases in Young's case report. Normally, in this case, is that many orthodontists extract the premolar, but in this case, she didn't extract. She gained the space for the canine. How did she treat all time? The other side is my case. As an extraction case. So anyway, This is very interesting and severely exciting. And anyway, there is almost highest cases. This high canine case is non-extraction. The upper molar is a totally distalization and slightly expansion, and she gained at the high canine case. So this is very, very interesting, and many orthodontists was surprised at this case after that. But this is fantastic. Yeah. The guide of this case is the completion of a class 1 molar relationship without premolar extraction in severe high canine case. This is a very excellent case, but I don't like the severe extreme case without non-extraction. In this case, normally I choose the extraction. So in this case, a setup model and for premolar extraction and the lower incisor, one incisor extraction, and the case is finished. So normally the premolar case, extraction case is bracket based. The step-by-step is as follows. The first premolar extraction, precision indirect bonding, customized bracket base, 18 slot bracket, sliding mechanics with pouch chain, resin stop, and upper arch is 1725 TMA, oxygen curve, lower arch is 1622 TMA wire, and gave the reverse curve. So let me show you step by step. Place the bracket and tube in the precisely positioned with the jig, transfer jig. Upper 16 by 16, 22 NiTi. Lower 16 by 16 to NiTi. After leveling, the space closure will start like this. Upper arch 1725 TMA accentuate curve. Lower arch is 1622 TMA reverse curve. And the resin stop, that is a total unmasked retraction device. So resin stop, the bracket and wire micro etching and bonding, and the power chain change 8 weeks interval. If we place the lower arch, after that, the next time, change the upper arch power chain, and step by step, finally, we gained. The space closing is very simple. The sliding mechanics is very useful. Don't use any more groove. So you place the bracket position precisely. You can choose that the upper and lower wire size differently. You can get this fantastic result. But nowadays, I have a question. Full cost class to molar relationship is the recommendable treatment goal. There is a full cost class to molar relationship. There is a full cost. There is a full cost class to. This case is a class 3 scatter pattern. So upper first molar extraction and space closure and the setback, mandibular setback, so that is induced full cost class 2. Class 1 is upper first molar major buccal cusp bite in the major buccal group. The functional cusp and the functional occlusal central first is placed. This cusp placed lower. Major buccal cusp and the major lingual cusp is placed at the lingual side. But full cusp class 2, but placed the marginal reaching, but lingual side like this. It's not good occlusion. This cusp placed only forceps, but this cusp placed on the marginal region, but not good relationship. But anyway, orthodontist, and even though the AAO permit this occlusion not so good. So this is better than, it's the best occlusion. This is not good occlusion. The functional cost plays the marginal region. So our graduate students study this case. Class 1 is good. And class 2 is good. But full course class 2 is not good. But if you try to full course class 2, don't do that. There is a material and contact area analysis, upper and lower contact area, and scan mesh and left from XOR3 software. Yeah. Significant difference between the class 1 full course class 2 and the mild class 2 and the full course class 2 molar relationship. That means class 2, full course class 2 molar relationship doesn't recommend anyway, yeah, not good occlusion. But in this case, it's only full course class 2 lingually, yeah, but rotational protraction. So if we place that protraction in the upper first molar, this case is a majorly rotation. Yeah, like this. So ABO, the American Board of Orthodontics model grading system. This is good, perfect. This is good, perfect. Class 3, lower premolar extraction in case the molar is perfect. No, the grading scale is a 0. Score is a 0. But in this case, not smart. In this case, score is 1, this is 2. But if you see the lingual side, this occlusion is better than full course class 2. So this is a end on class 2, a full course class 2. Full course class 2 score is a 0. End on class 2 score is a 1 or 2. It's a not good evaluation. That means molar occlusion is not important anymore. Okay? So, full course class to molar relationship, if you see that, cosmos-rich relationship. So, if you ask full course molar relationship, is that recommendable treatment goal? Answer, molar occlusion is not as important as the Orthodontic Association emphasizes. So don't move posterior teeth anymore. Full course class 2 is not good occlusion, even though, but the orthodontists recommend the full course class 2. But if you see the lingual side, it's very terrible. So molar relationship is not recommendable. It's not goal as molar occlusion is not as important as you recommend. So because of that, I focused only anterior part. Don't touch. Even though patient has a good mastication, don't touch posterior teeth because the orthodontist has a big dilemma. Yeah. This case is a spacing. So E-wire and elastic and velodrome wire. So before and after, we can easily only the elastic band, super chain, and EY and velodrome wire. It's very easy. Don't I didn't use. Yeah. Okay.
All right, thank you, Professor, for showing great cases. We still have a few more questions to cover. So there was one question on
Mastication breakage.
the mastication breakage.
Yeah, sometimes the 0.8 is very a small diameter wire, so the heavy bite force induce that wire breakage. So be careful. Yeah.
How can you correct malocclusion just E-wire only? Is it possible? And how to prevent or establish anchorage?
No, anchorage is so I mentioned just before. My focus is anterior part. So let me show you that the
위로 가서
이거. This case is crowding and lip protrusion. So I use that plate wire and traction elastic like this, and that the aligned like that. After that, E-wire and velodrome wire placed, and you know that the elastic, super elastic NiTi, and super elastic band, and like this. So now we're gonna use that aligner. Yeah. In this case, almost done, but minor detailing. We're gonna use that aligner. So like this. So if you want a detail and finishing is more recommendable for the patient occlusion, you can use that aligner, short term. Yeah.
finishing stages result compared to NiTi wires or stainless steel wires.
I don't use stainless steel wire anymore.
Not at all.
Yeah, not at all. Yeah.
Okay, and we have a few more questions we received through chat.
Maybe, Miss An, I would like to interrupt you. Maybe we can take that questions later. First, I would like to ask you to talk about our platform, our debrief platform, and whatever takeaways we have like shared and whatever they have received. So I would like to ask you to share your presentation.
So hello, good afternoon everyone, and welcome. I'm Lina from Dbridge. Before founding Dbridge, I studied dentistry in UK, and Miss Jaiswal has introduced my background. So after my degree, I have spent about 15 years in healthcare industry working on multinational companies in both medical and health sector. But by working in healthcare sectors, I saw the pain between the company side and the doctor side. There was a bit of gap between the two parties where dentists really need the clinical training, but then it's often neglected by the industry where they just focus on like pricing and the features of their product only. So there was a huge gap between innovation and the real world application. So my aim is to close that gap, and so that the doctors across the world can really solve their clinical challenges day to day. And we are here to really grow with you by empowering you with the right clinical sets and also the greatest clinically proven vetted products from Korea. We created Dbridge as a space where dentists can really do have a continuous learning from peers and experienced speakers across the world. And the more you really participate on our platform, our whole idea is that the more you get engaged with us, you can get rewards based on your participation. So you can unlock exclusive like benefits, including sponsorships and opportunities for training abroad or at local level as well, KOL or research collaborations, and access to both local and international speakers, and invitation to serve you as a guest speaker at our events as well. So we are here to really support what you need in your clinics, and we really want to grow with you as a partner as well. So please do join our platform, and we'll keep you posted on the latest updates with the new innovations and technology, and also the clinical skills from not just limited to Korea, but globally as well. Thank you.
Okay, so this is our social media platform where you can join us. And we also have courses regarding minimal invasive surgeries like filler, Botox, and rhinoplasty, etc. And these are some of our key highlights. We have participated in AOMSI and other large dental conferences and facial aesthetic conferences like APAC. This is our team members, like we are small but impactful, and these are our global partners. And currently we have these dental products we have with us, like synthetic bone graft and Newdent Profloss, which is very good. I'm also trying, and as a dentist, I can say that this floss is really very good. And yes, you can contact us. If you have any queries, you can contact us. And I would like all the participants to kindly scan this QR code. And just this is a survey. You have to do it. And if you want, we can connect later. And with Professor Chun, you can discuss your own cases. So it is a great opportunity. So I would like to ask everyone to scan this QR code. And I will also share in respective emails. So this is the feedback survey. And yes, certificate will be issued only after completing the survey. So kindly scan it. I will also try to add it in the chat box. Thank you, everyone. And now I would like to take up the question. Yes. So let's start with the first question, which is from Dr. Harmeet Kaur. Okay. Can you please show spacing case, any auxiliaries needed for spacing case?
스페이싱 케이스에 추가나 뭐 장비 같은 게 필요한 게 있는지.
이건 그냥 통역을 그냥
네.
해주세요. 스페이싱은 일단은 그 슈퍼체인이라고
네.
라이트 포스 릴리징 일라스틱이 있어요.
네, 네,
이 전치부에는 그냥 그거 살짝 붙여주고
네,
구치부에는 와이어로 그 고정을 좀 해주고
네,
벨로드로 저기 우리 플레이트 와이어로
네,
그리고 그냥 거기다 고무줄 감면 싹 들어가거든요.
네.
그런 다음에 안쪽에 벨로드로 와이어 붙여주면
네.
스페이싱은 해결돼요.
그래서 안티리어 쪽에는 슈퍼
슈퍼체인,
슈퍼체인.
슈퍼체인 굉장히 라이트 포스.
Yeah, so anteriorly, I recommend using light force super chain, but then lingually,
벨로드로
yeah, velodrome wire.
After space closure.
After spacing, yeah, space closure.
Yeah.
Okay, next question is from Dr. Gaurav Srivastav. What are the limitations with generalized spacing and Bimax cases? Please explain with biomechanics.
조금 전에 내가 보여드렸던 발치 공간 핏의 그 슬라이드 있잖아요.
네.
그걸 원리를 알면
네.
별로 어렵지 않다.
There's one case, one of the cases he has introduced during presentation, extraction case. If you understand the biomechanics of that particular case, then yeah, this would explain this question.
Yeah.
And how to express torque with E-wire?
토크는 일단 레비얼과 링구얼 두 개의 와이어를 쓰게 되면 토크는 전혀 문제가 안 된다.
Because you're using two wires, labial and lingual, so this doesn't compromise the torque that you have with normal bracket wires.
보통 브라켓을 쓰면 한쪽에서만 뭔가 그 루트를 움직이려고 애를 쓰는데 바깥쪽과 안쪽을 두 개의 와이어를 쓰면 의외로 쉽게 해결이 된다.
Actually, in fact, if you're using conventional bracket wires, you are trying to move roots from only one side of the teeth only, like labially. But then this one, because you are actually using force from both sides, actually it's easier.
It's very easy.
To apply torque.
Okay. The next question is, can we do in impacted canine case?
임팩트 캐나인을 끌어내려고 애쓰지 마라.
Don't too much effort. His advice is to protrude canine,
특히 견치가 나올 공간이 없다면
especially if there's no spacing.
그냥 내버려 두거나
Just leave it.
나중에 문제가 생기면 그때 발치를 하고
Only if it causes problem later on, then consider extracting it.
많은 그 교정 의사들이 견치가 굉장히 중요하다고 생각을 하기 때문에 결국 견치를 살리겠다고 뭐 여러 가지 노력을 한다. 다 부질없는 짓이다.
Things that many dentists want to preserve canine as much as possible, and because they think it's very important. But from his perspective, after all these clinical years, he thinks it's quite meaningless to put in so much effort to really preserve that.
이미 잘 나와 있는 소구치가 견치랑 비슷하게 생겼으니까 그게 물론 견치보다 기능이 조금 떨어질 수는 있지만 소구치를 죽이고 견치를 살리는 것이야말로 미련한 짓이다.
So he thinks it's extracting premolar to preserve canine is he doesn't prefer. He would rather prefer to just make use of premolar that's functioning well.
사실 이거에 대한 에비던스는 없다. 예를 들어서 견치를 해놓는 것이 소구치보다 훨씬 기능이나 이런 면에서 유리하다고 한 아티클을 내가 본 적이 없다.
He has never seen a study where there's proved that actually like functionally canine is better than premolar. So
매복치는 공간이 있으면 끌어내려고 애쓰는 게 맞지만 뭐 없다면 그거를 살리기 위해서 소구치를 빼거나 어금니를 뒤로 보내는 프로시저 같은 거 하지 마라.
So when there's spacing, it's okay to protrude, but then put in efforts for that. But if there's no spacing, try not too hard to really save canine.
Okay. Next question is from Professor Mohammad Mustaq. Can we attain the finishing goals that are necessary for long-term stability?
long-term stability를 얻기 위해서는 결국은 치아는 끊임없이 움직이기 때문에 항상 그 치아를 움직일 때 이 크라우딩이 로테이션 되어 있는 치아들은 치료 중에 가능하면 좀 지켜봐라.
You just need to closely monitor because anyway, over time, teeth tend to move anyway continuously. So you just have to keep on monitoring and then take action when you sense something.
보통 그 유지장치라는 게 전치부에 국한되어 있기 때문에 우리가 지금 벨로드론 와이어는 그냥 전치부에 밀착시켜서 그 코렉션을 함과 동시에 피니싱 됐을 때 그냥 리테이너로 쓴다. 그러니까 리테이션에 대해서 더 이상 고민하지 마라.
Because after you finish a treatment, usually whether it's removable or all these retainers, they only focus on maintaining the result of treatment on the anterior teeth. So with the velodrome wire, it plays a role where it does align the teeth, but then after treatment itself, it still works as a fixed retainer anyway. So it acts at both functions.
Okay, so next is thank you for Gurkirat Singh. Oh, okay, thank you for an insightful lecture. Very interesting. Sir, we will get back to you because you are a panelist member, so we want to hear from you too. Okay, next is from Ajay Kubawat. How about torquing and translation?
Torquing.
Yeah, we actually covered it just now.
Yeah.
Translation.
The translation is a translatory movement, right? Yeah.
Okay.
Translatory movement. So the plate wire is the plate wire는 two type로 쓸 수가 있어요. The first type is edgewise type. The other type is ribbonwise type.
Ribbonized.
Yeah, that wire is a very flat wire. So the flat side bonding the posterior part, though that is edgewise bonding, but the right angle upside, there's a the ribbon-wise bonding. So if we use that ribbon-wise bonding and the thicker size, and you use that power chain, it's very translatory movement is no problem.
Yeah, because if you remember the what do you call it?
Wire.
Yeah, the velodrome wire, the cross section, plate wire. Okay, plate wire has two types of
plate wire 다시 한번
네, we'll just show you.
plate wire. This is plate wire.
네, 이거 share screen.
Kindly share screen. Yeah.
Plate wire.
And just
감사합니다.
This side place that right. This is edgewise. This is ribbon-wise.
So one side, as you can see, is edge wire.
Yeah.
The flat side is so ribbonized. So it has two.
Ribbon-wise placed and bonding the wire. That's a translation is easier than.
Because it adheres to teeth to surface very well. There's a flat surface, so yeah, translation is achieved very well. Okay.
Okay. And then next one is from Dr. Mustafa, again our panelist member. How effective is the E-wire if you use it in conjunction with aligner for complex tooth movements?
Okay. The aligner, I recommend aligner is a final stage. The first step is Y only. The space closing, as I mentioned before, the elastic super chain and the plate wire and the roughly correction and the labial and lingual E-wire and the velocity wire and the space closing. After that, we use that aligner.
Yes.
It's collaboration.
Okay.
Just to add on, yes, Professor John highly recommends hybrid treatment with aligners.
Hybrid, yeah.
So it fastens the process of whole teeth aligning process. Yeah.
Okay. So actually we are running out of time. So now maybe you can send your questions via email and we will answer it accordingly. Okay. And yes, now I would like to request our panelist member, Dr. Gurkirat and Dr. Mustafa, to share their insightful remarks or any expert perspective on today's webinar session on E-Wire. And we would greatly value your thoughts and takeaways from this session. Over to you, Dr. Gurkirat.
Oh, we are very happy that you, Professor, introduced us to a new system. And Lina and Sandeep, I am pretty sure that you guys can make it available to us in India. And it looks very prospective. And since it is more or less, very aesthetically pleasing, I'm sure that we will be able to use it in our day-to-day practice. Thank you so much for the insight.
Thank you. Thank you so much, sir. Now, I would like Dr. Mustafa to give their insightful remarks.
Thank you. Thank you. Thank you very much, Professor, for a very clear and engaging presentation. I really appreciate how the concept focuses on the simplifying orthodontic treatment and also improving the patient comfort. The cases also what you have shared, it makes the approach very easy and related to everyday practice. It was a very interesting and engaging session. Thank you, everyone.
Okay, guys, thank you all for joining us today. We are truly overwhelmed by your enthusiastic participation. And we will be launching very soon a study group. And those who are interested are most welcome to join us. Together, let us bring or let us be a part of this revolutionary change in orthodontic practice. We kindly request your genuine feedback, and it helps us grow and improve. And on behalf of Debridge, I extend our heartfelt gratitude to Professor Chun, our esteemed panelists, Dr. Gurkirat Singh and Dr. Mustafa Sharif, and of course, to all our participants. We look forward to welcoming you again in our next webinar session. Until then, keep spreading smiles and incorporate our motto, that is learn, apply, share into your professional journey. Thank you and have a wonderful evening, everyone. Thank you, guys.